Hello, everyone, and good afternoon. And thanks so much for joining us for this very special Ask the Experts Facebook Live in honor of Thyroid Cancer Awareness Month. My name is Steve Blanchard. I'm a member of the public relations team here at Moffitt Cancer Center. But we have two Moffitt experts here today to answer all your questions and share the latest on the topic. So joining me are Dr. Sarimar Augusto Salgado, who is an assistant member in Moffitt's Head and Neck Endocrine Oncology program, and Dr. Kristen Otto, who is a head and neck surgeon here at Moffitt Cancer Center. Thank you both so much for taking the time out and being with me today. I really appreciate it. Before we jump into the questions that I have, I want to remind everybody who's watching that please submit your questions for our experts underneath this video box so that we can get to those and ask those to our experts for you. And we'll do our best to get as many of those in as possible in the time allotted. But also remember that we cannot offer personal medical advice or any diagnosis via Facebook. And remember that all of your comments are also public. So please keep those in mind while we move forward. So again, I want to thank Dr. Otto and Dr. Augusto Salgado for joining us. And to kind of get started, kind of on a high level, Dr. Salgado, I'll probably start with you. What exactly is the thyroid and what does it do for us?
The thyroid is an endocrine gland located in the anterior neck. It's in the shape of a butterfly, and it produces hormones that regulate multiple functions in the body, from heart rate, how quickly our heart beats, about movements, energy, and it's an essential hormone to have under control.
So of course, if that cancer impacts that, it will hurt the regulation of those hormones, I would guess, is where that problem lies.
Not necessarily. A lot of the times, thyroid cancer can present as a silent thyroid nodule or mass that might be found incidentally via non-related imaging during physical examination of the neck, or if it's causing any related symptoms.
So that leads me to I guess my first question about, thyroid cancer is what are the symptoms of it? And is it something that you feel physically with your hand? Is it a voice situation? How do you know that something needs to be checked?
In the cases that present symptomatically, it could be either a visible neck or palpable neck lump. It can also present in cases where these nodules or masses are having any effect on the nerves that control the voice, as hoarseness, sometimes issues swallowing. But many times it actually does not show up with any symptoms, and it's found, as I mentioned, incidentally in somebody that was having an unrelated imaging, and incidentally a thyroid nodule was found, and eventually the workup of the nodule led to thyroid cancer. I must clarify that not all nodules are cancerous. Actually, the big majority of thyroid nodules are benign, and a small subset only is associated with thyroid cancer.
So when someone comes in to, like you said, they're getting probably checked for something else, and then something is discovered, what is typically the next step of that? Is there lab work involved? Is there more scans that follow that?
Yes, we evaluate patients that have a thyroid nodule with a comprehensive neck ultrasound to look not only at thyroid, but also looking at all the levels of the neck, as we all have lymph nodes, which are part of our immune system. But we want to see if there's any suspicious abnormalities in any of these associated neck lymph nodes. We do check that the thyroid function is normal via blood work. And depending on a thyroid nodule size and characteristics, there are several classification systems that allow us to predict what is actually the risk of malignancy and determine when is the appropriate time to do a biopsy. A biopsy or a fine needle aspiration is done ultrasound guided, and based on the results, sometimes we can get right up front a diagnosis of cancer versus no cancer. Sometimes, if the biopsy is not completely conclusive, we can send the sample for additional molecular testing that can give us a better estimate if we're dealing with a thyroid cancer, so that we can proceed with timely management.
Okay, and I know that everybody's cancer journey is different. Treatments vary, the amounts, things like that. But Dr. Otto, I wanted to bring you in on the conversation from a surgical standpoint. At what point do you and your team step in and it's okay, time to discuss surgery? When do we get to that point?
So there's indications for surgery for both benign, for our indeterminate, and also for our malignant thyroid nodules. So sometimes we do surgery for benign nodules because they're growing, they're causing symptoms, difficulty swallowing and whatnot, or they're cosmetically, unappealing. You can see a lump in the neck, and many patients don't want to deal with that. So surgery for benign nodules is appropriate for sure. We then have a whole group of patients that we take to surgery for what we call indeterminate nodules. Those are nodules that don't look purely benign on a biopsy, but they don't have all the characteristics that would make a diagnosis of cancer. They're somewhere in the middle. There's atypical cells or there's suspicious cells. So oftentimes we do surgery for those nodules to try to make a better determination whether they truly are malignant or whether they're benign. And then of course for thyroid cancer, and we know that surgery is actually the mainstay of treatment for thyroid cancer. There are some adjunctive therapies and some additional therapies that we occasionally use, but surgery is definitely, by far the mainstay of treatment for thyroid cancer.
Okay, and if you're just joining us, please feel free to drop your questions into the chat. Here's your chance to ask anything and everything about thyroid cancer with these two experts from Moffitt Cancer Center, and I'll be happy to relay those to both of those experts. I'm curious on if there's different types of thyroid cancer, and Dr. Augusto Salgado, this might be for you. Are there different types, and what are those?
Yes, the most common type of thyroid cancer is actually papillary thyroid cancer. We divide basically thyroid cancers in several groups, and the most common are what we call differentiated thyroid cancers, or thyroid cancers like papillary, which is more than 80% of all cases, followed by follicular thyroid cancers. We have some 40 differentiated thyroid cancers and that is basically classified based on how the cells look under the microscope once our pathologist does the analysis after surgery has been performed. The most aggressive form of thyroid cancer is anaplastic thyroid cancer, which can present as a rapid growing mass, and it's an oncologic emergency. And we also have other rare tumors of the thyroid, like medullary thyroid cancer, which is actually what we call a neuroendocrine tumor, and can be associated in about 25% of cases to a familial syndrome. So definitely having an accurate pathologic diagnosis is very important because it can impact the extent of surgery and the treatments that follow that first line of therapy.
Now, one thing you just said, Dr. Augusto Salgado, was familial. So does that mean that there is a genetic disposition for some to develop thyroid cancer?
In the majority of cases, we do not necessarily find a familial association. Specifically for medullary thyroid cancer, 25% of the cases can have what we call a germline mutation, meaning an alteration called RET in all the cells of the body, predisposing to other tumors besides medullary thyroid cancer. And so that's why all patients that have medullary thyroid cancer, we refer for genetic testing. In addition, there are certain occasions where papillary thyroid cancer, there's several first-degree relatives in the family that have papillary thyroid cancer. It could be a familial association. At Moffitt, when we evaluate our patients, we do obtain a comprehensive family history to see if there's any other predispositions, because there are certain syndromes like Cowden's that can be associated with thyroid nodules and thyroid cancers, and we have a very nice genetic counseling department where we see a strong family history of not only thyroid cancer, but other conditions. We certainly involve them in the care of our patients.
And to kind of follow up on what you said, and this is one of those situations where I'm not sure which one of you wants to answer this, so I'm going to throw it to both. We have Eileen who's watching, and she asked, what is the standard follow-up for papillary thyroid cancer treated with surgery only? And I'm not sure which one of you would be appropriate to answer that. So.
I can take that. So our standard follow-up is that we want to make sure that patients are cancer-free after surgery. And surgery only could actually be a very small tumor, which is treated with a partial thyroidectomy, or it could be maybe a slightly larger tumor, which is treated with a total or complete thyroidectomy. Generally, the follow-up for thyroid cancer includes an office visit for a physical examination, a comprehensive ultrasound of the neck, and blood work. And we do that about twice a year for the first 2 years. If the patient appears to be cancer-free and they have a good response to treatment, then sometimes we step down to just once a year after that.
Okay, so it's kind of I don't know if maintenance is the right word, but you keep an eye on them for a while to kind of see what the next appropriate step would be.
Like with any cancer, there is a chance of recurrence. With early stage papillary thyroid cancer, that chance is very low, but we don't, completely ignore it. And so surveillance is what we call it. Surveillance after definitive treatment, in this case surgery, is about every 6 months for 2 years, and then once a year following.
Okay, and I think we kind of answered this question already. One of our viewers, Pat, is asking, do benign nodules need to be treated? I know you said that some of them do undergo surgery, but do they need to be treated if they're not a health risk, for example? Or
not really a hard and fast rule for what needs to be treated, and generally it's a discussion between the endocrinologist, the patient, the surgeon, about their sort of wants and needs. And so, my kind of take home for benign thyroid nodules is we take them out, we remove them if they are symptomatic. So if we can prove that those nodules are causing compressive symptoms for the patient, a sensation when they swallow or a sensation when they lie flat, then there's an indication for surgery there. If the nodule is growing and we think that it's going to continue to grow, generally patients will choose surgery so that we take it out when it's smaller rather than when it gets much larger. Or if we believe that although the biopsy came out benign, that there's something that looks funny about that nodule, that we're worried about it clinically, that would be another indication for surgery. Not all benign thyroid nodules have to be treated at all. And really it's just a discussion with the patient to make sure that the patient's needs and our recommendations are sort of in check.
of course, it goes back to that personalized treatment and making sure that everybody's on the same page and getting done what needs to be done. Which leads me to a question. We talked about the genetic side of things. And Dr. Augusto Salgado, maybe you can answer this. Who is at risk of thyroid cancer? Say if I don't know of anybody in my family who has had thyroid cancer, obviously that doesn't mean that I'm not going to someday encounter it. So who is at risk for this?
Certainly, exposure to radiation has also been associated as a risk factor, and more recently, obesity has been linked to multiple cancers, and thyroid cancer has been shown to be a risk factor. But in many cases, we don't necessarily are able to identify the risk factor. There are ongoing studies to find what we call endocrine disruptors in the environment, meaning that there could be potentially eventually more risk factors identified based on how frequently we see these diseases. But as of this point, what we talked about has been the main risk factor so far.
Okay, and I know that again, everybody's environmental situation is different, so it's really hard to nail it down. And I'm assuming that there's a lot of ongoing research to try to get those answers, right? This is an ongoing quest, I guess, to figure out where this comes from. Now, if we talked a little bit about the symptoms earlier and how sometimes there aren't symptoms, is there a way to regularly screen for thyroid cancer? For example, I know that we do head and neck screenings at different events out in the community here at Moffitt. Is the thyroid screening part of that?
I can talk about there's really no strong recommendations for routine screening. We know that ultrasound is really the best test to get a close look at the thyroid gland to determine whether there's any nodules. Part of any general head and neck exam is going to include feeling for thyroid nodules, but unless a nodule is larger, I would say probably more than 2 centimeters, it would be very difficult to reliably palpate a nodule during physical examination. So really, there's no recommendations for routine screening for thyroid cancer. It's really more about treating nodules that come to be obvious by physical examination or symptoms.
Okay, and if someone does have thyroid cancer and does need to have surgery, Dr. Otto, how long does surgery typically take in this situation, and how long are they in the hospital following?
So the surgeries obviously are very variable depending upon the stage of the cancer, involvement of lymph nodes, for instance. So I'm going to take a step back and just say that by far the most common type of thyroid cancer, as Dr. Augusto pointed out, is papillary thyroid cancer. This tends to be a very predictable tumor, and it tends to be one that is very non-aggressive and very responsive to treatment, which is why oftentimes we can get away with surgery alone as therapy for this type of cancer. This is not cancer that's super aggressive that we tend to use other modalities such as radiation, chemotherapy, and whatnot. So papillary cancers being very predictable, they love to spread to lymph nodes, and that's generally the pattern of spread. And so before we decide on extensive surgery, we have to make sure that we do a comprehensive test of, and this is by ultrasound, to look for any potentially involved lymph nodes. If we find lymph nodes, we prove that they're positive by biopsy, and then we can include them as part of the surgical procedure. So a small thyroid cancer that is in one side of the thyroid gland that is completely contained within the thyroid tissue, we generally recommend thyroid lobectomy or partial thyroidectomy for a tumor like that. That operation takes about an hour and a half, and patients go home same day. It's outpatient surgery. A larger thyroid tumor, or one that we believe has already spread to lymph nodes, we prefer total thyroidectomy as the best treatment. And with that, we sometimes also go further and remove lymph nodes as well. Those operations can obviously be longer. A total thyroidectomy is about a 2-hour procedure. If we add in neck lymph node removal, that could make it 3 or 3.5 hours. And generally, those require overnight or even over 2-night stay in the hospital.
And you know, a thyroidectomy means the entire thyroid gets removed, correct?
Mm-hmm. Yeah, so partial thyroidectomy, half of it's removed, and total thyroidectomy, the entire thing is removed.
Okay, so when that happens, obviously the thyroid's no longer there to offer that hormonal support we talked about before. So I'm assuming there's some kind of step after that. I don't know if it's a hormone therapy, drugs. What does that look like?
Yep. One of the reasons why we really scrutinize thyroid cancer very closely to see if we can perform, more conservative surgery is that for patients who undergo partial thyroidectomy, sometimes we can avoid the need to have to put them on thyroid hormone replacement medication in the future. Only about 20 to 30%, maybe a little higher, maybe 40% of patients who have partial thyroidectomy actually have to take hormone pill afterwards. For total thyroidectomy, of course, you're absolutely right, Steve. Patients need thyroid hormone replacement following surgery, and that's done usually in the form of T4. There's 2 types of thyroid hormone, T3 and T4. T4 is a long-acting thyroid hormone, and we usually give a pill, a T4 pill, after surgery. Most patients get to the point where they can take that pill once a day, but it's lifelong. If you've had a total thyroidectomy, that's something that you will always face, is the need to be on that pill. It does require verification that you're on the right dose and that your thyroid hormones are at the levels that we want them, and that's done through blood testing postoperatively.
Okay, and thank you for explaining that. Roberta, who's been watching, has a question that she framed it better than I could. It's about after the surgery, and she asks, is it normal to feel enlarged lymph nodes more than a year after a thyroidectomy? Is that typical, and what are the side effects of a thyroidectomy?
I wouldn't. It's not typically related to the thyroidectomy. So, I would say that it depends why the thyroidectomy was performed. Was it for benign disease or was it for cancer? Of course, the fact that thyroid cancer does tend to spread to lymph nodes, I would want to be certain that lymph nodes are investigated postoperatively if they are still feeling like they're enlarged postoperatively.
Okay. And going back to you, Dr. Augusto Salgado, I'm curious, from the clinic side of things, when you have that first conversation with somebody who has been diagnosed with thyroid cancer, what is that like? Because everything I'm hearing sounds like that it's survivable and treatable, but nobody likes to hear the cancer word. So what is that usually like whenever you first diagnose somebody?
First of all, one of the things is providing a patient's knowledge about the specific condition, the specific type of thyroid cancer. If we do the diagnosis preoperatively, ensuring that they see a high volume surgeon like Dr. Otto to make sure that they have the best surgery up front, and ensuring that we have the appropriate imaging beforehand, talking to them about the different staging system and prognosis. And once I also see them after surgery, we can can estimate based on how big the tumor was, if the amount of lymph nodes that were involved, what's the actual risk of recurrence. The risk of recurrence also allows us to ensure that we have the proper surveillance. How many times do we need to see them a year? It also tells me if I need to do any additional therapies like radioactive iodine, which is a special type of treatment that is used in thyroid cancer, mainly in basically in differentiated thyroid cancers like papillary and follicular, because the cells do still have the property of capturing iodine similar to normal thyroid cells do in order to function. So we take that to our advantage, and in patients that have higher risk of having recurrences, we can do radioactive iodine treatment after surgery. In terms of the psychological support, we do know I'm a strong advocate that there's no good cancer, even though our patients, majority of them have a good prognosis. It's been proven that there is a psychological and a financial burden from being diagnosed with any cancers. So at Moffitt, we do have support groups at the level of the nation. There are also good quality support groups. We have a comprehensive team over here at Moffitt for those cases that present with more advanced disease or cases that eventually stop responding to the traditional therapies. I work a lot with that patient population, and fortunately the landscape of more additional targeted therapies and auto chemotherapies keeps evolving, and it also highlights the importance of having a good multidisciplinary care. Right here at Moffitt, I function as an endocrine oncologist, and I share many cases with Dr. Otto and other surgeons here. And we have a communication, not only weekly tumor boards that we come together and individualize the plan for our patients, but even if we need to communicate offline among ourselves or radiation oncologists, nuclear medicine, we have excellent social workers. We have all the resources that we need to take care of patients with thyroid cancer at any stage, and just ensuring that we have that good communication, and that and we spend a lot of time on our initial visits and our follow-ups to make sure that the patient is aware where we are.
And I know that a lot of times people say sometimes the treatment is worse than the actual cancer. And Pat is asking, are there risks associated with radioactive iodine treatments? And what are those risks and or side effects?
So radioactive iodine, it's a bit different than, for example, the external beam radiation that is used in other head and neck cancers. Radioactive iodine, we prepare patients by making them transiently hypothyroid, usually using an injection to allow that ability of having the body capture that radioactive iodine. There's certain occasions where we can do that by timely and purposely holding off the thyroid hormone, but that is under strict medical supervision. And once the patients receive the radioactive iodine, some can experience transient taste changes because the radioactive iodine in its oral form can also be associated with absorption in the salivary glands. Some can experience a transient salivary gland inflammation that might occur right after the radioactive iodine, or may happen intermittently in time, and we do have some supportive measures to make those more manageable. More recently, there's been some data about a slight increase of other malignancies in patients that have been treated with radioactive iodine. As of right now, we don't have necessarily a specific guidance on screening for other cancers on patients that have had radioactive iodine. But what I personally do is I periodically check the white blood cell counts, and I encourage my patients to have healthy lifestyles and ensuring that they have the age-appropriate malignancy screenings when they're due, including mammograms, colonoscopies, and etc.
Okay. And this goes back to something that we talked about a little bit about, I guess when it metastasizes, if that's the right term I'm using here. Bob, who is watching, asked about if it metastasizes to neck lymph nodes or a lymph node outside of a lung, something like that. What is that treatment like? Is that an entirely separate surgeon? Is that done by you, Dr. Otto? Is that a lung surgeon? How does that develop?
Well, I guess it depends. If thyroid cancer metastasizes to a lymph node in the neck, generally a head and neck surgeon or a head and neck endocrine surgeon like me would treat that. Even nodes in the upper part of the mediastinum or the sort of chest cavity are oftentimes easily accessible through an incision in the neck. And usually those procedures would be combined or done at the same time as the original cancer, if you know about it at that point. Those procedures are combined with the thyroidectomy procedure. And that's why we advocate for comprehensive preoperative evaluation, including neck lymph node ultrasound, so that adequate staging can be done, so that the adequate operation can be done first time around to cut down on the risk of recurrence in the future. If the nodule or if the thyroid cancer actually spreads to the lungs themselves, that would not typically be treated by me, and that's something that we would make a decision depending on how many nodules there are, how many lesions there are. We would make a decision about role for radioactive iodine, for some of those oral chemotherapy agents that Dr. Augusto was mentioning, or even sometimes external beam radiation. It becomes a little bit more personalized at that point.
Okay, and thank you for explaining that, because I do know that there's so many parts of the body, and cancer can travel. So I know your expertise is definitely head and neck, which was why I'm glad he asked that. Now I wanted to shift gears a little bit. We've talked a lot about the medical treatment and what is physically done, but I know that early on, and I can't remember which one of you shared this, but you talked about your speech can be impacted when it comes to thyroid cancer. I know speech pathologists play a role in recovery as well. I was wondering if one of you could expand a little bit upon that, or maybe both of you.
The thyroid gland sits in the front part of the neck. Dr. Augusto mentioned that. And it's not really the speech that's impacted, it's really the voice and the strength of the voice that can be impacted. It's actually pretty rare for the thyroid to impact the voice, and it would have to be a very invasive cancer that causes voice changes preoperatively. And really the reason is because the nerves that control the vocal cords run behind the thyroid lobe on either side. They're right there behind the gland. And so if a tumor in the back part of the thyroid gland grows and becomes invasive outside of the thyroid gland, it can actually invade around or surround the nerve, causing the nerve to be weak, which then causes the vocal cord to be weak. And typically that manifests as a weak voice. It's a breathy voice that sounds more whispery. So patients who just have a scratchy throat or who have a little bit of hoarseness, that's generally not related to the thyroid gland. The other time that the voice can be impacted related to the thyroid is during surgery. So it's one of the main things that we think about intraoperatively is finding that nerve and then protecting it and keeping it safe during surgery. But with any thyroid surgery, there is a risk of injury to that nerve. I think it's important for patients who are seeking thyroid surgery to understand each surgeon's personal risk of injury to that nerve. And we, are a high volume thyroid center here at Moffitt, and we can say that our injury risk is around 1% or less for thyroid surgery. So this is surgery that can be done very safely, and the anticipation is normal voice following surgery. We do a couple of things to try to ensure that happens. Number one is everybody who is going to have thyroid surgery by me and by my colleagues here at Moffitt will get a preoperative test called a laryngoscopy. And this is a scope procedure that is done in the office during your office visit, where we actually put a little camera through the nose after we anesthetize the nose. And we actually look to make sure the vocal cords are working normally preoperatively. That way we can document and know that there's no impact of those nodules on those nerves before surgery. During surgery, when patients are under anesthesia for surgery, of course, under general anesthesia, requires a breathing tube be placed. And we use a specialized breathing tube that is embedded with surface electrodes that sit up against the vocal cords on the inside. And we can actually use that to monitor the nerves on the outside using a little electrical stimulus probe. That's called intraoperative nerve monitoring, and that's used for almost every thyroid surgery, for certainly every thyroid surgery by me here at Moffitt Cancer Center. That technology does not prevent us from injuring the nerve, but it certainly does allow us to track the nerve and make sure that we understand how it's behaving during surgery so that we can predict whether a patient's going to be weak postoperatively. If there is a nerve injury or if there's a cancer that's invading the nerve and the nerve has to be sacrificed during surgery, you're absolutely right, Steve, that we can engage our speech-language pathologist postoperatively. Many times patients can have voice therapy and actually recover a pretty meaningfully strong voice, even with a nerve injury. If not, there are some vocal cord augmentation procedures that can be done to try to get a patient's voice back to, pretty close to their preoperative baseline. So although it is an issue and it's something that we think a lot about, fortunately, injury is not common, and when it is, there are things that can be done to help.
I understand, and I saw Dr. Augusto nodding a lot along while you were saying that. Dr. Augusto, is there anything you wanted to add to that point?
I think she covered that point beautifully.
Excellent. You were singing her praises. I saw as she was talking. We have Marlene who's been watching, and she asks if kidney cancer happens to be prone to go to the thyroid. And back to that metastasis situation, is where does, so let me broad upon that. She asked about kidney cancer to the thyroid. Are there cancers that are kind of related to the thyroid as far as metastasizing goes? And again, Dr. Augusto, I'll shoot this one to you.
So I think there's 2 points I think we can make with this very valuable question. So other cancers spreading into the thyroid, like being the thyroid, gland a place where other cancers like lung cancer or kidney cancer would spread to, it's actually pretty rare. So many times when patients are coming, let's say to Moffitt to have other cancers, and during the scans a thyroid lesion is found, it's usually a thyroid nodule and something separate from the thyroid, from the cancer that they're being treated to. Now, going back to thyroid cancer as a primary cancer, we had talked about that most commonly the place for it to spread to would be the neck lymph nodes. Only in a subset of papillary and follicular thyroid cancer patients, I would say between 10 to 15% of all those cases, the thyroid cancer can spread to other places, and usually the most common place is the lungs and the bones. Medullary also, besides those two sites, can sometimes have a liver metastasis. So we have talked that these different types of thyroid cancer, besides the neck ultrasound, we incorporate some blood test that serves as tumor markers, and based on that initial risk of recurrence, myself as an endocrine oncologist, I incorporate into their surveillance if I need to be imaging any additional other place of the body besides the neck lymph nodes. For those patients that have metastatic disease, the actual treatment depends on the thyroid cancer. For example, if it's papillary or follicular and there's a distant metastatic disease, as Dr. Otto mentioned, we evaluate if we can still use radioactive iodine. Sometimes by the clinical history and the features that I'm seeing on the imaging, I know that radioactive iodine might not be already the best option, or that the tumors have become resistant to radioactive iodine. And then we see what's the pace of growth. Is it a threatening location? We consider as a multidisciplinary team if we can do focal radiation or a directed therapy, or if there's another surgery that can help me go back the clock to active surveillance. And for those cases that we're seeing a more rapid progression, we do have some oral anti-cancer therapies that we can use to treat a metastatic disease. We have some general chemotherapies that I can use orally for thyroid cancer that would work against multiple types. But one of the things that we do is we use either a biopsy from an accessible size, or we use the surgical pathology to be sent for something called molecular testing, which lets me know what is that cancer driver to see if I have a more specific oral treatment that I can do that would function as an anti-cancer treatment. So I hope that answers the question, but happy to. go over if anything.
I think it did, and it goes back to our point earlier. Every cancer journey is different. So answering something so specific can be challenging because there's so many different ways that cancer can move. And uh, I want to remind everybody who's watching that if you do have questions, make sure you get them in. We are kind of getting to the tail end of this, so if you do have questions, make sure you add those to the chat below the video. But I did want to go back to Dr. Otto. I had a question for you regarding surgery. We talked a lot about where the thyroid is located. I mean, it's right in front. So I'm curious about scarring. Nobody wants to scar. Well, maybe some people do. But what does that look like for a patient? And if there is a scar, is there like a reconstructive surgery part of this as well? Can we talk a little bit about that?
There's several different approaches to thyroidectomy, but scarless thyroidectomy, which has been sort of tried and has been done through various access points, has never really taken hold. The thyroid is right under the skin, and so the most immediate and easy access point is to make a small incision in the skin of the neck. Usually for just a standard thyroidectomy or a standard thyroid lobectomy, we can get away with about a 2.5-inch incision. Usually we can hide that in the natural crease line of the neck, and the neck is being so well vascularized is a part of the body that tends to actually heal quite nicely, and often these are very subtle incisions. I wouldn't even call them scars. They're very subtle incisions that heal quite nicely. We do have to lengthen the incision, usually still in a natural crease line of the neck. If we're going to include neck dissection or neck lymph node removal as part of the operation for a thyroid cancer, again, these are usually incisions that heal quite nicely and are very cosmetically acceptable.
Okay, and that makes perfect sense, and thank you for explaining that. Or grow a beard and you can't say anything, so that's a good way to do it too. Going back to
luxury, but yes, that's another.
Yeah, not everybody. So very, very valid point. Going back to you, Dr. Augusto, based on what you were just saying a few minutes ago, before I was asking about the scarring, Pat was wondering if you have a secondary cancer in addition to thyroid cancer, how does a patient know, or how do you determine which clinic or doctor takes the lead on treatment? Because we've talked a lot about the multidisciplinary approach here at Moffitt.
Yeah, so if we're talking about metastatic thyroid cancer that has gone to multiple places, then an endocrine oncologist like myself or a medical oncologist tends to be the lead physician guiding the oncologic care. And we have, if we're talking about a patient that has lung cancer or kidney cancer and also thyroid cancer has been found incidentally, then usually at Moffitt, we collaborate with other departments. I encountered this situation, for example, frequently. And what we do is to minimize the financial impact and the impact of having scans and surveillance. We coordinate with the oncologist treating the other cancer. We determine the timing of treatments, what needs to be done first. And usually I coordinate my scans with the staging imaging that it's being done for other imaging. So we do work together with the medical oncologist that's specialize in that area. So centers like comprehensive cancer centers like Moffitt, just as Dr. Otto and myself are very focused in thyroid cancer and myself in endocrine tumors, we have also for the different cancers, multidisciplinary team of specialists for breast cancer, for kidney cancer, for lung cancer. And those teams also come up together to decide the best treatment for the patient. So when we have an intersection of two different malignancies, we also make that communication happen, putting the patient in the center and individualizing what needs to be done first.
Of course, and that's, again, you said comprehensive cancer center, and that's exactly how that works. Before I say goodbye to the two of you, I wanted to ask one last question. This is for both of you, and I'll ask Dr. Otto first. Anything that we didn't touch on or that you wanted to share about Thyroid Cancer Awareness Month, about treatment, about surgery, that we didn't get a chance to really touch on in the short Facebook Live? And Dr. Otto, I'll ask you first.
I think we covered most of it. I will echo Dr. Augusto's comments that thyroid cancer, like many cancers, we feel is best treated in a multidisciplinary team format. While we recognize that surgery is the mainstay of treatment for most early stage thyroid cancers, other treatments, including long-term thyroid hormone supplementation, is certainly part of the package deal. So seeing both a high-volume thyroid surgeon as well as an endocrinologist focused on thyroid cancer is extremely important. We think here at Moffitt, or as much as we can, we try to bring patients in our multidisciplinary teams so that when you come in for your visit for your thyroid cancer, you can meet both an endocrinologist and a surgeon, or have those appointments fairly close together so that you can hear not just the necessary primary treatment, but also the long-term surveillance strategy. And then the other thing I'd like to kind of focus on is that we do try to personalize and individualize therapy for our cancer patients, even with thyroid cancer. And so, you mentioned earlier that there are some long-term side effects related to use of radioactive iodine. And while in the past, everybody with thyroid cancer was given surgery plus radioactive iodine, we don't do that these days. And we have a high-level discussions within our multidisciplinary group about which patients and which tumors really deserve that extra line of treatment with the radioactive iodine, and which ones we can avoid that extra line of unnecessary treatment. So we are always trying to refine our recommendations for therapy. Again, whether we do a partial thyroidectomy, whether we do a total thyroidectomy, whether we include lymph node dissection, whether we include the radioactive iodine, is all very individualized and all very evidence-based. So I think that's probably the extra couple of pieces of information that I'd like to get out to the group of patients online. And I stress the importance of seeing a high volume thyroid surgeon who is focused in thyroid cancer, as well as an endocrinologist who is focused in thyroid cancer.
And thank you for sharing all that. Again, there's so much information out there, and I know there's tons of questions that people have. So covering all of them in one Facebook Live is not easy, but we will definitely do this again. And Dr. Augusto, same question to you to kind of wrap things up. Any final closing remarks that you want to share?
Well, first of all, thank you to the audience that logged in today with very valuable questions. I echo Dr. Otto's words. It really does matter where you come to receive treatment for thyroid cancer in terms of that multidisciplinary discussion. The field has been evolving amazingly over the past few years, and putting you as a patient in the center, it's the most important thing. As of right now, there's some newer revolutionary approaches that sometimes, if we find, for example, an advanced tumor, we can sometimes consider an auto-targeted therapy first and see if that can make the surgery less extensive and not complicated. But those are usually decisions that are made by experts like us who work with this disease every day. For those patients that have rare tumors like medullary or anaplastic, centers like us, where we are on the cutting edge of the newer therapies, can really make an impact even on survival. And so I highly encourage that if you or any of your family members is suffering from this disease and has questions, highly consider us as a team. And for all of the thyroid cancer warriors out there, we support you. We hear you as somebody who had a family member who battled with this disease. We are strongly advocating for you, not only in our day-to-day clinical encounters, but at different forums that we, as experts, get to participate outside Moffitt. So we're very thankful of you entrusting your care to us, and for this opportunity to raise awareness on thyroid cancer.
And perfect for September, Thyroid Cancer Awareness Month. And thank you, Dr. Otto. Thank you, Dr. Augusto Salgado, for taking the time out. I know you're both very busy. There's a lot going on at Moffitt all the time, but I do appreciate you taking the time to chat with me and to answer these questions that came in from our viewers and from our audience. And of course, I want to remind our audience that this video will, of course, live on Facebook. It'll also be available on YouTube to share with others. But if you have specific questions about your situation and you want more information on thyroid cancer and details about our endocrine department, great starting point is moffitt.org. You can get all the information there and also learn more about our two doctors featured today. Thank you, everybody, for tuning in. Thank you, doctors, again, for your time this afternoon. Be well, stay safe, and we'll do this again soon.
Thank you.
Thank you.